Hi, so we left off with the next level of how we understand evidence-based approach, which is not just through looking at empirical evidence. We want to be clear that it is important, the scientific evidence, but in addition, we also need to understand what the client, the caregiver, are willing to do. So if we're relying on a behavioral approach, because the evidence says that's what works best with ODD, and the behavioral protocol is for the parents to chart the child's behavior every day, and to record how many times he or she acts out. And the family is very stressed already. They have multiple children. They're both working two jobs. They may not really be willing or ready to or able to implement that kind of a strict behavior protocol. So we do know that we have to work with the family. We take whatever elements from that scientific evidence that we can implement with the client, with the caregiver, and we make the best case for using the evidence and doing something feasible. The article that you read about evidence-based practice really focused on how sometimes the feasibility of implementing evidence-based practice is very limited. They were concerned about this third part of the triangle, which is the clinical expertise and our training. And so if we know that eye movement desensitization response is the best approach for a trauma survivor, but we've never been trained in EMDR, then we can't use that evidence-based approach. So EBP relies on three parts of the triangle. What the research says has the best potential for being effective given the presenting issue of the child or client, child or family member. What our own training and expertise is in, what we're capable of doing, what we're going to be able to get supervision for doing, sometimes what our agencies will allow us to do, and then thirdly, what is the client able, willing, and ready to do. So we have to really put all three of those lines of the triangle together in order to create the evidence-based practice approach that is most feasible, most reliant on the external scientific evidence, but can be implemented in a way that is pragmatic and that will actually be carried out. There's a lot of evidence and there's a lot of judgment that we have to make about the evidence. So we really have to realize that that research course that you took, or those two research courses that you took, actually have some validity and some practicality in terms of us becoming clinicians. We can read research, but we have to be critical consumers of it. We have to realize what the evidence shows and what it misses. So we really need to take a informed approach to our research. So when we read a study, we need to know what the methods were and whether it was a very rigorous study that maybe had random assignment to two treatments, which really shows whether one treatment is superior over another, not just whether treatment is better than nothing, and we're able to rule out all those threats to internal validity, all those other variables that are extraneous, because we were able to use random assignment, and all those variables were randomly distributed between the treatment group and the control group. On the other hand, if we read a study and it's only a one group only study, we did a pre-test and we did a post-test, and we gave the kids the treatment, and we show that, oh, the kids are better after the treatment, so it's really before and after effects. We can't rule out very much, including the fact that the kids might have gotten better over the time between the pre-test and the post-test, even without any treatment. So that kind of study, we can use it, and we may that may be all that we have, and we have at least a study that shows, well, the kids got better after the treatment than before, but we have to be realistic and rational about the fact that that evidence is very limited. It's not great evidence, it's a little bit of evidence, as opposed to we have a study with 3 groups where one group got just attention, the placebo, one group got the treatment itself, and another group got nothing. Got nothing at all, not even attention. And we can show that the group that got the treatment did better than the attention control group or the nothing control group. Now we can rule out a lot more variables like time, maturation, history, because we used random assignment, attention or placebo effect. And so that kind of study is really much better. And even better is to really understand that there's a whole hierarchy of evidence for intervention studies. The first level of evidence is just what others say. Opinion, anecdotal, narrative, what your supervisor says, what another clinician says. Oh, this worked with this child before. And that can be of some use, but we have to realize it's at the lowest level of evidence. And then we go up the hierarchy to look at increasingly rigorous data, so that after that becomes, okay, well, there's a descriptive study, but they only collected qualitative data, but there's a nice narrative that goes with it that suggests that the child really did better afterwards, but we don't have a randomized control. We don't have, we're not able to control for a lot of variables, and we're not sure how valid or reliable the data are because it was really only descriptive and qualitative without reliability or validity test. But if you get a review of a number of qualitative studies, that's at a higher level. And then once we get into the quantitative range, we want to get to the point where we have randomization, where we know we can rule out all those threats to internal validity you learned about, history, maturation, sampling bias, the statistical regression to the mean. And we know that if there was a change in the treatment group, and it was a bigger change, a better change than in the control group, then we know it was due just to the treatment alone and not to all these other extraneous variables. But one RCT, or randomized controlled trial, is not enough to really say, hey, this treatment really works. At the highest level of evidence is where there have been replication studies, and there's been multiple studies that have shown consistently that this treatment works better than other treatments, or this treatment works better than treatment as usual. And those are referred to as systematic reviews or meta-analyses, and those are often also called literature reviews, which I think you're probably familiar with. We will be reading those, and those are the best things to find as a clinician, because somebody's done a lot of the work for us already. They read all those 20, 30 studies over the last 5 to 7 years, and they've synthesized it all, and they come up with conclusions about which model really has the most consistent results, or the conclusion might also be no model works better than another, they all work equally well, or no model works at all, they all work poorly. But that gives us the information that we need to know, if we use this model, what is the potential for it to be effective with this child. We will be reading literature reviews or systematic reviews of several evidence-based approaches as we look through each of the disorders throughout the semester. Now, if you're a more visual person, here's a nice visual about the hierarchy, and it's in this pyramid form. It gives you the same information, and it talks about at the very bottom of the hierarchy, the least rigorous, but some use, are what other people say, what our supervisor says, what our colleagues say has worked well, and sometimes that's all we got, and so we use that. Then we can go up the hierarchy and sometimes find studies, randomized control studies, cohort studies, that show that when we do this with a group, a large sample, the majority of the sample do better than the group that did not get this treatment. And then if we're really lucky, we'll find these systematic reviews or meta-analyses. So that's what we want to be on the lookout for as evidence-based clinicians that are working with children and adolescents. When we want to, when it's time to decide what strategy, what approach, what intervention should we be using with this child? We want to use an evidence-based assessment, which I'll talk about in a few minutes. And the assessment, as I said, is really key, because if we didn't assess correctly, then we're going to try to match an evidence-based approach with the wrong diagnosis, the wrong disorder. Once we know an accurate assessment, then we can often find research literature that shows what model has the best likelihood of being effective with this child, and that's the one that we are going to use. Now then we go to the child and we go to our own training and we find there are some limits there. Then we often have to adapt. We have to adapt that model to make sure that the child is actually going to carry out that research. I'm sorry, not that research. That model is going to let us do those strategies with us, and that we know enough to do it and we have enough supervision. The reading that you had really focused on this idea that it's very difficult to implement evidence-based approaches because they cost money, they cost time, they require training, they require supervision, but it's worth it. We really need to work toward using the best evidence, and sometimes we may not be able to implement the model in the exact way that it was implemented during that pristine research study that was university-based, but we take whatever elements out of the evidence-based model that we can implement, that our child will do, that our family will do. So maybe they're not going to behavior chart every day, every minute of the day, but I've used behavior charting where I ask the family, okay, during the evening when everyone has a little time together and you have a little more downtime, observe your child just during an hour and chart the behavior then. So we can adapt these evidence-based approaches to the client preferences, and so we go back to that triangle, to the client preferences and abilities and time, and to our own expertise and our own ability and our own training. And so that's what we try to do. We try to do the best we can with the best evidence, doing it as pragmatically and as feasibly as we can, and that's our goal. Okay, well, and the reason that we want to do that is because there's a heck of a lot of evidence. There's a lot of research that's been done. It's really been growing exponentially in the last 10 years. And we need to take advantage of that. We can't say, we used to be able to say there isn't a lot of evidence, but there is. And so we're not really good clinicians if we're not keeping up with that literature and keeping up with that research. Given Google Scholar, the DSM-5 itself, the amount of access to information that we have, there's no reason that we can't take an hour and look for, or even 20 minutes, and look for at least one study or a literature review that says what's going to work best with this kid who has a phobia, what's going to work best with this child who seems to be depressed all the time. We will find a lot of research. The areas of research that have been most that there is the most substantial body are listed here, with the exception, I don't know how I left it out, anxiety disorders should be here as well. So the research the disorders that have been researched the most are listed: ADHD, ODD, conduct disorder, depressive disorders, also anxiety, and PTSD. A lot of this research is integrated into the DSM-5. It's how they've developed the criteria, it's how they know what the risk factors are, and what the course of the disorder is going to be. There's also some research that's a little harder to find, but if you look, you'll find it, and that's not so integrated into the DSM-5, but it exists. That's research on sleep disorders and feeding disorders in very young children. Now, if you look for research on eating disorders, you'll find a little bit more of that, and that is not been as integrated into DSM-5, but it's available. The two areas where there's not enough research, and we really need to do more research, are listed at the bottom: RAD, or reactive attachment disorder, and bipolar disorder in children. So reactive attachment disorder is one of the least researched areas in terms of efficacy. there's very little known about what is effective with children with reactive attachment disorders. Consistent caregiving, of course, is key, but other than that, what the intervention is, what the treatment is, what we do as clinicians there's not a lot of evidence about. So that's a growing field. We need to know more. And then bipolar disorder in children does not have a lot of research on children. There's a lot of research on adults, and we can't just generalize that research on adults to children, because children are very different. They present very differently. And by the way, bipolar disorder is way overdiagnosed in children and young adolescents. I see it all the time as the diagnosis when it really doesn't fit the presentation of the youth. So I'll talk a lot about that in one of our sessions, so I'll let that go for now. We don't know some things, though. Even though there's a lot of research, there's some gaps in our evidence base. One gap is specificity, meaning we don't really know what the active ingredients are. So we know that a cognitive behavioral approach to anxiety disorders works well. For example, if we teach the child relaxation skills, and then we teach them the cognitive behavior triangle, then we help the child identify and maybe even create a hierarchy of those things that make him or her anxious. And we practice, we do in vivo and virtual exposure, where we have the child think about and then actually face the thing that creates the anxiety, while we help them relax and stay relaxed, and we teach them coping skills. We look at their cognitive distortions about the thing that makes them anxious, and we help them come up with new thoughts that are more valid and more reliable, and thoughts that don't make them really anxious. If we do that enough with most children, that does reduce the anxiety. But we don't know specificity. We don't know which of all of those things, and I mentioned a lot, which of them are the most, which ones are the things that work and the things that are just like, well, it's nice to have them, but it's not really critical. So we don't know what the actual specific active ingredient, if you will, is. So if we took out exposure, if we took out relaxation techniques, but we don't really, as clinicians, I don't really worry about that as much, because whatever works, I'm going to use, and I'll put it all together, and I'll use it, and I'll keep using it until it helps the kid, or it doesn't, and then I try something different. Finally, let's not forget that the effects of the therapeutic alliance are really important. I'm going to skip to the next slide, which really looks at or asks the question, what really accounts for client change, and to what extent is it that practice model that we use, evidence-based model, to what extent is it client characteristics, or any of these other three things? And actually, Lampert has done a study, but it's not a great study, and I don't put a lot of store in here. I don't think these percentages are real percentages, but I think there is a relative difference. I think that probably the client characteristics, which is the yellow, is probably one of the most important features. So how motivated is the client? What are their, how severe is the disorder? How long have they had it? To what extent is their family support? All the things that make it easier for the client to get well, those are really critical. And Lampert suggests they take up about 40% of the variance in the outcome for the child. Then the next biggest factor, the green, is the therapeutic relationship with the child, with the adolescent. And that's that therapeutic alliance. That's that understanding that our ability to connect, build rapport, relate, create trust, create a therapeutic relationship or a therapeutic alliance is key, and we never can forget that. In some ways, it doesn't, if we don't have that, it doesn't matter what evidence-based model we use. That's not going to work. Lampert suggests that the model itself, which is the blue, probably accounts for about 15%. And again, I'm not so attached to these numbers. It probably is a little less important than the therapeutic alliance, but it does account for some variance. It is important. And then the final is the expectations of the client. Someone who really just thinks that this is all nonsense and they're not expecting anything to work and they don't really want to invest in the work, whether it's a child or a family member or a parent, that's really going to take away from the viability of the work that you're doing. So we need the buy-in of the client. We need to use an evidence-based model. We need to develop a strong therapeutic alliance with our kids and their families. And we need to hope that we increase their motivation, increase their investment, help them get ready to change. And sometimes we have to use things like motivational interviewing because they're not ready to change before we use that evidence-based model that we know will work once they are ready to engage in change. So that's part and parcel of the idea that evidence is important, and we should be using the best model, but it has to be matched with client preferences, and we have to build that therapeutic relationship and that therapeutic alliance. Okay, let me go on real briefly to talk about standardized scales, or one of the components of evidence-based assessment. So one way to do evidence-based assessment is to use standardized scales that have been identified, that have been researched, that have been tested on hundreds and hundreds of children, where norms have been established, and the reliability and validity of the instrument has already been established. So there's plenty of evidence-based or standardized scales around. Some of them are better than others. Some of them have been tested on only very small groups, and some of them have been tested on larger groups. There's lots of advantages to standardized scales. So if I am working with a child who I think is depressed, and I give that child, or the child's parent, if they're too young to take it themselves, the Childhood Depression Inventory or the Beck Depression Inventory, I know that all of the potential symptoms, all of the presentations of depression are being asked about, and I'll get some indication of at what level the child is experiencing each of those depressive symptoms or factors. And if I just interview the child, I may miss some. So this is a more systematic coverage of the behaviors that contribute to the disorder. It also helps me because it compares this child with the larger population of children of the same age, race, and gender. Yeah. In addition, it tells me if there's a threshold, if that child is above the threshold and actually meets the criteria for clinical depression, or if their score is low and actually falls well below the threshold for clinical depression. And even though they may have a few depressive symptoms, they're not meeting the criteria for a disorder. And sometimes it can be helpful for especially adolescents or middle childhood kids that may not be ready to talk to us, especially in the first few sessions, but they're willing to write something down or enter something if we give them a online computerized inventory. So those are some of the advantages, but there's plenty of disadvantages too. All standardized scale rely on self-report or collateral report. So the data that we collect are only as good as the validity and reliability of the reporter. So parents are usually trying their best to report as accurately as they can. They're not great reporters about mood and anxiety because that's stuff going on inside the child. Now, some parents are very tuned into that, some parents are not, but we're not, it's not a given. In addition, there may be inaccuracies or just lack of knowledge, and parents are just guessing. So the data, again, is really subject to the fact that it's self-report or collateral report. So the child or adolescent is reporting it, or someone important to them in their lives, like a caregiver, is reporting it, or a teacher sometimes. A big disadvantage is standardized inventories are time-consuming. Some of them are 50 items, 100 items, they take forever. They're very tedious to do. They require a certain level of literacy and comprehension and may not be really appropriate for some populations. The reliability and validity of the instruments vary, and it's our responsibility to know, is this a reliable instrument to use with a 6-year-old Latina young girl? Or is it never been tested on girls, 6-year-olds, or Latinas? And if it hasn't, then it's probably not reliable and valid for this particular kid. So we really need to take some time to look at the reliability and validity. And then finally, there's these two biases: social desirability response bias and exaggerated response bias. Social desirability response bias, I'm sure you studied this in research, is that we say we often want to make ourselves look better than we might be. So if you ask about how many times a parent who uses physical discipline hits their child, they may underreport it. Or if you ask me how many times I went to the gym, I might overreport it. So there's social desirability because we want to make ourselves look better. There's also this exaggerated response bias where there may be some cultural tendency to exaggerate. And so I think of some of the adolescent males that I work with. So if you ask them about aggression or sex, they may give you a little higher level. They may overestimate the actual response. So we have to be aware of that and understand that there's limits to the data, even, and not reify it, not make it feel like this is exactly what this child has or does. Okay, two types of assessment tools. Some are broadband. That means if I don't know anything about this child, I don't know if they're depressed, if they're anxious, if they're disruptive, if they have autism, I may want to do a broadband assessment tool. And these are some of the most popular ones: CBCL, the BASC. Those are the two most popular. There's also something now called the APA cross-cutting measure, which is can be found at apa.org, and you'll see it listed. It's a free measure. I do use that, and I'll actually bring it to one of our classes so you can get access to it. You can access each of these tools through these websites, and you can read about their reliability and validity and who they've been tested on. The problem with the CBCL is it's 105 items. It's ridiculous. 120 items? Yeah, it's really long, but it's one of the best tools in terms of reliability and validity, although sometimes we don't get great data from it. So it has its downside. It's also, you have to purchase it, so that's another issue. If we know that the parents are coming in, the child is clearly aggressive, externalizing, showing a lot of acting out behavior, we may cut to the chase and or the child is totally inattentive or totally hyperactive. It's very clear that this is an externalizing syndrome, and we may use not a broadband tool, but a more specific rating scale for specific syndromes. And so these are some of the ones that are used for externalizing syndromes. These are some of the ones that are used for internalizing syndromes, and some of these are very well researched. The BDI and the CDI are probably two of the best. The Reynolds Adolescent Depression Scale, I haven't used it, but I've read that it's pretty good, but I can't speak from my own experience of that. Some of the anxiety scales and social phobia inventories are around, and there's a lot of PTSD reaction scales. So you can find them on the internet. Some of them are free, some of them you have to buy. All of them you want to research a little bit and find out validity, reliability, who have they been tested on. And they can add to our clinical formulation. It's really important, though, to observe the child and to interview the child and not just give them a paper and pencil to fill out. So we don't want to rely exclusively on scales, and sometimes we don't use them at all. Sometimes our own clinical interview is the best. We want to play with the child and really engage. In order to create the clinical formulation, which you're going to do an exercise with, so I'm not going to go into detail on the slides about. Dawkins talks about two kinds, the biopsychosocial and the formulation based on a time axis. You'll be looking into that more on the written assignment. And then, of course, when we decide what treatment or intervention we need to use, we're going to put together all that I just talked about. We need to review what is known about efficacy, effective treatment for the specific disorder once we know what it is. We need to draw from the evidence-based conclusions. What does the literature say? Are there literature reviews? Are there meta-analyses? We need to look for consensus on what approach has the best potential to be effective with this particular child. And then we need to collaborate with the child. What are you willing to do? What are you not willing to do? Some kids love exercises that they draw or write or play, other kids won't touch them. And so you may find, well, the evidence says this workbook works really well, but I got a kid that's not going to do anything with paper and pencil. Maybe I'll take the workbook and I'll use it in a way that is based on just verbalizing, telling a story, narrating, and getting the child to just talk to me, but I'm actually implementing the exercises in the workbook without letting him know. So it's really got to be some mutuality between what the client wants to do, what he's willing to do, and what the research says. Okay, but we're always trying to find the evidence-based approach which we feel has the best potential for effectiveness and the one that matches the client preference so that we can actually use it and carry it out and it will be implemented in a true way. Okay, that's it for this tape. I'll see you soon. Bye.